Good evening, everyone, and thank you for participating in this evening's webinar. This is part of the Midwestern Vascular New Horizons webinar series, and it is entitled Vascular Screening Patient Access. We'd like to thank Medtronic for sponsoring this program, and we would like to remind everyone for tonight's webinar, please use the question and answer button to present any questions that you might have. My name is Robert Molnar. I'm a clinical professor at the Department of Surgery for Michigan State University. I'm the Associate Program Director for Sparrow's Integrated General Surgery Residency. I'm also chair of the SBS Clinical Practice Session. I'm joined this evening by our co-moderator, Gene Starr, who's the Senior Director of Medical Safety, Structural Heart and Aortic Peripheral Vascular Health Operating Units for Medtronic Incorporated in Columbus, Ohio. We're very fortunate to have four presenters this evening. We have Joe Harani, Jordan Knepper, Rachel Nicholson, and Jay Cho. So this evening we will start with the four presentations, and I'll turn it over to Dr. Starr, who will introduce our first presenter.
Thanks, Dr. Molnar. Yeah, I'd like to go ahead and introduce Dr. Joe Harani, who is my old partner. He will deny that, but he's currently associate professor at Ohio State and is the director of the non-invasive vascular lab. And Joe's going to talk to us about AAA and PAD screening and what are the guidelines. Take it away.
All right. Thank you so much for having me. And I want to again thank the moderators for participating tonight and helping us move the sessions along. Obviously, I want to thank Medtronic for the generous support, and then all the committee members from the New Horizons for inviting me here to give this talk. So, PAD and PAD screening. What is the importance of this? Sorry, I skipped through the disclosures. No financial disclosures. I'm the PI or sub-PI, but nothing that's really relevant to my talks. So, when we look at the importance of screening for abdominal aortic aneurysm, obviously we're looking for any aorta that are over 3 centimeters or larger. Interestingly, when you look at the prevalence across the world, places like the United Kingdom, New Zealand, Sweden, and Denmark, the overall prevalence of aortic aneurysm has decreased, we think in part owing to better screening, but also better awareness of the disease and reductions in smoking. So now it's down to 1 to 3%, whereas it was up to 7% several decades ago. Unfortunately, in the United States, we lag a little bit behind this, and we have a much harder time ascertaining the actual prevalence rates because our screening rates aren't as robust as in other countries. Most aortic aneurysms are asymptomatic until they rupture, so we can't overemphasize the importance of screening to prevent the main outcome we care about in aortic aneurysms, which is death. So just want to briefly go over the history of aortic screening in the United States, because I think it's an interesting endeavor that overlaps physician groups, industry, our government, CMS, a wide swath of participation in order to get screening approved, which is kind of an interesting problem because you would think that it would be a sort of a intuitive thing that you'd want to screen. But it wasn't until 2007, about 50 plus years after Medicare's inception, that it finally became part of Medicare approved services. So in 2007, Medicare approved through legislation from Congress, a one-time welcome to the Medicare screening visit, aortic aneurysm ultrasound. This legislation, called the Screening Abdominal Aortic Aneurysm Very Efficiently, or the SAVE Act, was actually not an independent legislation. It was part of the budgetary amendments and law that President Bush signed into effect on February 8th of 2006. So when we look at some of these healthcare changes that get enacted in our country, more recently with some of the cuts that we're seeing through CMS and some of the legislation that's been enacted as part of like the COVID relief bills, you see that we often have to work with our legislatures to get these rulings put in place, and often have to attach them on to other larger, broader incentives. So when you take a look at what was involved to get this done, they initially approved it for male who were ever smokers and men and women who had a family history of aortic aneurysm. If you look back, only about a decade and a half ago, the estimated cost was only about $200 million to screen over 5 years, which if you look at other healthcare initiatives, that's pretty cheap. Interestingly, the National Aneurysm Alliance is the one that helped to really push and lobby for this bill. And if you look at who made up the membership of that, it was a coalition of about 18 medical groups. And these included everyone from medical groups such as the Society for Vascular Surgery, the American Surgical Society, and others. But there was patient groups involved, and there's also industry involved, right? So this was a multi-party stakeholder group that was able to lobby Congress to get this passed. And if you noticed, these are some of the companies that you'd expect, such as Gore, Medtronic, Boston Scientific, Cook, et cetera. If you look at the uptake of this, there was only about 10,000 people that were at risk that were screened in that first year, which is not great uptake. So this got revamped in 2009 to get rid of some of the barriers, such as that one-time welcome to screening exam, so that you could broaden who could get it. So it wasn't just the initial enrollees. And they also uncoupled it from directly needing legislation, and they made it so that the Health and Human Services would be more flexible and allowed to follow the U.S. Services Preventive Services Task Force, U.S. Preventive Service Task Force recommendations. So that way the future updates could be done through CMS independently, so you didn't need legislation each time. The two figures that I put up here are just people are, if you're wondering what this took as far as a financial cost, the lobbying group spent $120,000 in 2004, $240,000 in 2005, and then they only did half a year of lobbying in 2006 and spent another $140,000. So relatively low cost. So the impact that we can have as a society is pretty significant if we pool our resources within ourselves, but also with our colleagues that treat similar diseases. I just put a brief plug in there for current legislation and stuff that we're looking at as the year ends. But again, we can be very impactful, and it doesn't take huge dollar amounts. Okay, so what happened to the UPSTF recommendations? If you look at the pre-legislation, they basically looked at saying that there was insufficient data and they didn't really recommend broad screening. They revamped that a little bit in 2014 to have a strong recommendation for men 65 to 75 who have ever smoked, less strong of a recommendation for non-smoking men 65 to 75, and kind of said based on other risk factors. They had a don't screen recommendation for women who were never smokers, regardless of family history listed in there, and then insufficient data for women who were ever smokers. So you can see even as recent as 2014, still not a lot of robust recommendations for screening broadly, pretty limited recommendation. This got revamped a little bit in the last couple years. The men 65 to 75 who have ever smoked is still a strong recommendation, one-time screening. They included some more definition to the men 65, 75 who have never smoked to kind of better define those that are at higher risk that would benefit potentially from this. Still have the do not screen recommendation for women who are have never smoked, but did add in sort of this not enough evidence, but maybe consider it in women who have smoked, especially with a family history. So how does this tie in with our own professional society's recommendations? Ultrasound is our modality of choice when feasible, and that has pretty good evidence behind it. One-time ultrasound screening for men or women ages 65 to 75, especially with a history of tobacco use, again, is a little bit more broad than the USPF group recommendations. And then first-degree relatives, not as strong of an evidence base, but still recommendation by the SVS. And then the folks that are older than 75, the importance there is what is the likelihood that they're going to live long enough to benefit from that screening? In other words, if they didn't have an aneurysm at 65 to 75, if you screen them at 75 and you find a 3-centimeter aneurysm, but they're frail and have cancer, et cetera, are they going to be around long enough to benefit from the survival benefit of finding that aneurysm or not? So duplex for screening, non-invasive, very sensitive and specific, right? Over 94 to 98% on those. And when you compare that to other screening modalities, the main advantages are it's much better than physical examination. There's, the US population, unfortunately, obesity rates have risen significantly, and it's pretty hard to palpate something along somebody's spine. So sensitivity and specificity physical exam is just not adequate. You can look at things like CT scans and MRI, but when you're looking at incremental cost of those tests and whether they're better at screening than ultrasound, there's just not a cost advantage there. The interval screening, pretty good data, 7 cohort studies and 1 case control studies, over 6,000 patients that looked at AAA associated mortality in spans of 5 to 12 years. And it's very low if your aorta is less than 3 centimeters at the initial screening. So we have pretty robust data saying one-time screening, if it's smaller than 3 centimeters, pretty good chance that you're going to be around 5 to 10 years out. So if after that initial screening, I know we're getting away from screening here into follow-up, but just wanted to briefly mention, if it's 2.5, but less than 3, again, you're pretty safe for a long time. Between 3 to 4, it's 3 years, 4 to 4.9 annual checks, over 5 every 6 months. So moving from aneurysms to peripheral artery disease is a little bit more tricky. Here, the benefit of screening, right? Is it prevention of atherosclerotic disease? Are we looking to see, can we reduce amputation rates? Can we improve walking mobility, time that people are working, and so on? Or is the real benefit peripheral artery disease screening looking for cardiovascular disease, right? So is this akin to the coronary calcium score, that you're going to find people who have atherosclerotic disease and then make them live longer and better because you get them on the appropriate medications and treat them appropriately? So it's a little harder to pin down whether it's cost effective or not, because the definition of what we're looking for varies depending on what society cares about this and what patient population you're screening. So resting ABI is the most commonly used test to screen for PAD. We've been recently seeing an uptick in patients who have a home nurse that come out and will put a little toe cuff on the patient at home as part of just their annual well check, and if they have risk factors for it, and are and getting sent to us for referrals for PAD. So it can be important because it raises awareness. Whether or not it truly is a cost-effective way at reducing cardiovascular risk over time or reducing amputation and peripheral vascular disease remains to be answered. I'm not going to put a slide on this, but within the last few years, for example, there's been legislation proposed looking at whether or not reimbursement should be withheld for patients who get an amputation who didn't get PAD screening ahead of time, right? So little controversial. Obviously, not all amputation is the same as each other. But again, one of those issues that comes up, and just to be aware that this is something that is still considered and debated at multiple levels of government through present day. All right, not going to go over this in great detail. Obviously, it's very reproducible. We all know the cutoffs for the different degrees of peripheral artery disease. But when you talk about screening, right, there's physiological testing, but there's also symptom questionnaires. And I think that you're going to see more of a focus from CMS and others looking at patient-reported outcomes, and can we use that as a better way to screen for peripheral artery disease without the cost of some of the non-invasive testing. And then again, without some of the question of what do we do when you have an abnormal ABI and an asymptomatic patient. So here's some examples: the World Health Organization Rose questionnaire, Edinburgh modification of that, walking impairment questionnaire, San Diego claudication score. So what does the U.S. Services Preventative Task Services Force, long acronym, recommend? They say there's inconclusive data at this time. All right, so they don't really have a strong recommendation for or against screening to see whether there's a benefit in screening for peripheral vascular disease and reducing cardiovascular disease and related complications. The other trouble that we have with this is if you look at all the various large professional societies, European, American Heart, Society of Vascular Surgery, the Preventative Service Task Force, American Association of Family Physicians, we all have different recommendations on who to screen, when to screen. All right, so in brief, for the Society of Vascular Surgery, because that's one that we tend to care the most about, it's if you have an asymptomatic adult with no risk factors, really, there's no strong recommendation for screening. Patients that are over 70 with risk factors, smoking, diabetes, abnormal pulse exam, or other established cardiovascular disease, MI, stroke, it's reasonable to screen in those patients. But the evidence there, again, it's 2C. So overall, we just don't have great consensus on universal screening for peripheral artery disease yet. And with that, I want to thank everyone for their time and attention, and stop my slideshow.
Thanks, Dr. Harani. Those are some great points and some history probably that a lot of us didn't even know. I think we're going to hold it. We do have a nice question in the chat, but we're going to hold the questions to the end because I think some of the talks may overlap a bit and we can address them then.
So our next speaker will be Dr. Jordan Nepper, Assistant Professor of Surgery and Director of Vascular Labs at Michigan State University, and he's going to present on vascular disease discovery program. So welcome, Jordan, and please take the reign.
Well, good evening, everyone. Robert and Jean, thank you for moderating. Dr. Lynn, thank you for inviting me. I'd like to thank Medtronic for their sponsorship of the session. And Kurt and Stephanie from Medtronic, as you see, helped make my presentation look very nice. So I appreciate that. And thank you to the Society for putting on these great webinars. So to tie into Joe's presentation really nicely, we're going to kind of go through kind of the nuts and bolts of how we can move screening and screening-like programs with some technology into practice development so that we can optimize the number of people we see and really target the patients who need treatment the best. Medtronic, who sponsored this session, has some nice services to go with this, so we'll be going over that in some detail as well. I have no relevant disclosures, even though my slides make it look like I do, so thank you. So just as we all know, for level setting, the projected number of AAAs in the United States is around 2.2 million, with about 280,000 requiring treatment, but still have around 15,000 deaths per year. So what we can take from this data is there's still a good number of people that we don't capture in our existing screening programs that Joe so greatly discussed. And that there are additional methods that we can use to try and capture more people to both develop our practices and help those people acquire adequate treatment. So as we all know, once again, smoking history accounts for our greatest risk factor for ruptured aneurysms. And in PAD, we are main goal of amputation protection. 1 in 20 people over the age of 50 will be diagnosed with PAD. And if we can crosswalk some risk factors, we can really work on that to prevent amputation through targeted screening. And just like we were talking about ABIs or surveys to really do PAD screening, we can utilize our existing resources and our medical records to try and identify those at high risks for these conditions. Furthermore, we can utilize stroke risk factors as well, and really target those people and try and decrease the number of disabling strokes that occur. So with our screening programs, we're going to be focusing on as we say, aneurysm, amputation, and stroke prevention. So how can we do this? So we can expand access to people if we give early and targeted opportunities for high-risk patients to see specialists. And I saw there was a question in the chat that was kind of asking about that. And really, maybe this is where we can merge our screening with those people that don't necessarily meet those goals. So we can improve clinical outcomes not only with that, is we can decrease the number of amputations, we can decrease ruptured aneurysm mortality, and in some targeted venous screening, which we're not really going to focus on this evening, we can decrease number of ulcers. And that's really goes hand in fist with expanding access and allowing those people with these disease states to get earlier treatment, and some of those people to get the prophylactic treatment they need rather than showing up at the emergency department. And as in the previous presentation, there are these pay for performance measures, including screening going along with amputations. And this is another method that we can use to do that. Furthermore, as we talk about system metrics and pay for performance moving forward, we really need to optimize our cost and efficiency. And by preventing these high cost disease states, including venous ulcerations, amputation, and further stroke care, we can really target dollar decreases and show savings for these target disease states by really accurate screenings. So we can partner with industry in this, and the Medtronic aortic field team will really help you in this. And we're going through this in our system right now, where we can go through algorithm-based selection that will enter into your medical records after collaborating with your IT departments. And this is in a HIPAA compliant way, and we'll talk more about that. But with these algorithms, you'll get a spreadsheet output, and this will help drive early disease detection in at-risk people that may not have already been screened. Given this, we can target true screening imaging for those people rather than broad imaging, and allow higher detection rates and really allow better throughput so we can better utilize our resources. And then we can use our clinical practice guidelines with these to treat people before the end stage disease occurs. So the EMR query is a proactive approach. And really, we're going to talk about the AAA screening here tonight, because that's what we're going through right now and have the best experience with. But it will query your medical records. There had been a outside company that had offered this previously, and there was a good fee associated with this, but Medtronic has worked and now gives this to partnering physicians free of cost. They'll query your medical record in a HIPAA compliant way. Medtronic never gets your patient data. And then you will get a list of results of high-risk patients in your system's EMR data. And then that allows you to target screening and disease evaluations of those patients. So when we do that, things that we've done in practices to try and really help those people and still stay compliant with all of our laws is you can send letters to your PCP. You can meet with your PCP, say, hey, we're screening this. We're going to send you a letter about your patients that are high risk, and we're going to help you target your screening. And so you can be more compliant with your U.S. Preventative Service Task Force guidelines and your pay for performance metrics. Because in our ACO, screening for these things equates to dollars for some of our PCPs. There's a toolkit in the Disease Discovery Plus that allows you to not only bridge the gap between screening, but also allows people who haven't put in robust screening programs to get an ultrasound-based screening program in place for your hospital so that you can really target and give free or low-cost screening to these people and really allow points of entry and allow people to be treated before they hit the rupture. And then looking ahead, there's some AI technology that will come together in these care collaboratives, scan medical records, and help with decision makings to kind of further from our algorithmic-based treatment to AI looking forward. And as trials continue on those, I hope we'll have some better reports to do and discussions to have on that. So really my call to action and summary on this one is this is really a no-brainer to do. And whether you work with Medtronic or just develop your own algorithms and do it yourself, help your referring docs. Go through your common medical records, go through risk factors, send them a letter saying, hey, here's your list of people that we've screened. Here's our recommendations for testing, and then let us take care of those people. There are numerous people that have been helped through these programs. Even one large AAA found is a life saved that somebody would have otherwise had a ruptured aneurysm. And really my summary on there is elective treatment saves lives, whether it's amputation, prevention, or aneurysm rupture. Additionally, if you're developing a new practice, we can also bridge the gap from the right thing to do for your patients to the right things to do for your practice. This can show people you're out there, you're looking, it can bring people into you. And in a really compliant way, you can send a letter even to the patient saying, hey, you may be at risk for some disease states. Here's a list of specialists in your area, including yourself. Why don't you go and talk to somebody? And use your resources. This is simple. We already put all of this data into medical records and spend hundreds of hours risk stratifying our patients. Let's use that data to find those people that we haven't got to care for yet and really go forward to screen the right people at the right time. So that's the end of my talk, and I appreciate you guys this evening.
Great. Thanks, Dr. Knepper, very much for going over that program. And I think you maybe even did address that question in the chat, but we'll see how things are at the end here. We're going to move along, and I'm going to introduce next Dr. Rachel Nicholson, who is Associate Professor at the University of Iowa, and she's going to talk about optimizing patient access. Rachel?
Okay. Well, I'd like to thank the Society for the opportunity to talk tonight. And, the fallout from the pandemic has kind of served to magnify a lot of the longstanding barriers to patient access in ways that have had a really profound effect on many surgeons' day-to-day practice. So with that in mind, I thought I would focus on some of the challenges to patient access. So I don't have any disclosures for the purpose of this talk. So some of the barriers to access that I'd like to discuss tonight include socioeconomic and ethnicity issues, geographic challenges, and finally staffing shortages. The impact of socioeconomic status and ethnicity affects outcomes of after EVAR. A study from the nationwide inpatient sample database was performed by Lemaire, who looked at over 9,000 studies to see if there was a relationship between ethnicity or insurance type on the outcomes after EVAR. Those who were self-pay and had worse outcomes than those who had private insurance. Whites were also less likely to have had less perioperative mortality and postoperative complications than Blacks and Hispanics. In a study of the American College of Surgeons NIST database, all patients who had above knee amputation or below knee amputation, as well as all of those who had open or endovascular revascularization procedures for a critical limb ischemia from 2005 to 2006 were evaluated. Over 4,000 patients over 4,000 patients had open surgical procedures, and here's the ethnicity breakdown for those patients. A little over 500 had endovascular procedures with a very similar breakdown in ethnicity. But what was disturbing in the study is that of the 1,500 patients who had major amputations, there was a disproportionate amount of amputations among Black and Hispanic patients, with 29% of the amputations occurring in Black patients and 8% in Hispanic. Dr. Islami used the nationwide inpatient sample database to look at urban patients from 1998 to 2002, and those patients who presented with lower extremity ischemia. The groups were divided into an amputation group and a lower extremity revascularization group. Comorbidities, age, gender, race, ischemic gangrene at presentation, insurance, and income status were determined. There were close to 700,000 patients. 66% had revascularization and 34% had amputation. The figure on the right side of the screen shows amputation rates in Black and the lower extremity revascularization in white, with the columns categorizing by ethnicity, income, and insurance status. Higher rates of amputation were found among non-whites, low income, and those without commercial insurance. The rates of amputation were also noted to be inversely proportional to increases in income. Furthermore, at initial presentation, those with who presented with gangrene shown in Black versus those with without gangrene shown in white was also evaluated. The patients who were non-white and low income presented with more advanced disease, suggesting a delay in diagnosis in peripheral vascular disease, likely due to lack of access to adequate primary care and also vascular surgery care. So the authors suggested that better patient education aimed at the general population and primary care providers regarding the symptoms and consequences of PVD might reduce amputation rates in this group. So one thought on improving access is, considering the patient education material you use in the clinic, do all of your brochures look like this? For a long time, this is all that we used in our clinic. And, there's a certain demographic we're certainly targeting with this. We've certainly tried to broaden our patient education material a bit more, but this is something to at least take a look at. Obviously, it's not going to be, the fix to our problems, but it is certainly one way to kind of improve inclusivity and also improve patient access, and to ensure that you're showing that, yes, this is also something that you're trying to educate kind of all groups that are involved. In Iowa, we have a certain amount of geographic challenges because it's such a rural state. So looking at this, the Department of Health and Human Services has a number of data charts out there for looking at the supply and demand for vascular surgery in the future. The screen on the left, the chart on the left shows figures projected for demand of vascular surgery in orange and the supply in blue. By 2031, the lines will cross and the supply will likely meet demand for vascular surgery in urban areas with a slight deficit in 2035. However, in rural areas, which is on the screen on the right, the deficit between supply and demand is expected to continue to diverge, making it increasingly difficult for rural patients to access vascular care. Here's an example of the study of the effects of rurality on patients with atherosclerotic cardiovascular disease. The study of approximately looking at patients who had, kind of the all-encompassing diagnosis of atherosclerotic disease. looked at about 5% of the patients, which amounted to about 900,000 total, reported that annually they had delayed care due to transportation barriers. Vulnerable groups included young adults, women, low-income people, and those with no public or no insurance. So the study suggested that for future analysis, focus on the feasibility and potential benefits of interventions such as telehealth, mobile clinics, and provisions for transportation among this patient population. So, like I said, Iowa is a very rural state. It's not densely populated by any means. And we basically have zero in the way of public transportation options for our patients. And many of our patients drive 2 to 3 hours just to come to clinic visits. And often there's not local expertise in those rural areas where where a lot of them live. So it creates a lot of challenges to the longitudinal care of our patients. Dr. Mink evaluated some of the effects of rurality in situations like this and race and the risk of primary amputation, and found that the effect of rurality was on the risk of amputation was amplified by race. She sampled the VQI database for amputations. In non-white patients, there was a 21% higher odds of undergoing primary amputation overall. For rural non-whites, it was 2 times higher odds of undergoing a primary amputation than rural whites, and a 52% higher odds of undergoing primary amputation than urban whites. And in the urban setting, non-whites had a 21% higher odds of primary amputation compared to their white urban counterparts. So what do we do in our rural states? So, well, a large study on the benefits of telehealth came out of the University of Minnesota, in which a 5-year period of telemedicine consultations among VA patients in a large rural catchment area was reviewed. There were over 500 patients who participated in just over 700 telemedicine consultations, all conducted by 4 vascular surgeons and 2 advanced APPs. They did their visits at 21 different clinics across 5 different states, and the average distance from the main VA medical center in Minneapolis was about 159 miles. 75% of these were new patient visits, and the 25% were follow-ups. And after the initial consultation, over half of them were booked for procedures. So they were able to demonstrate that telemedicine is a solution that can replace in-person visits, particularly for those in remote locations with difficult access to vascular care. Telemedicine increased patient convenience, decreased travel expense and wait times, and it can also improve the catchment area of your practice. So some of the shortcomings they discussed included the incomplete visualization exam for patients who were especially undergoing open surgery, and also the inability to palpate pulses occasionally led to some last-minute changes on the day of surgery. Within the VA system in my local area, we also are incorporating telemedicine, and it's a very wide catchment area. The range is 150 miles from east to west, up to 300 miles north to south, and it covers 3 different states and 50 different counties. And especially at the height of the pandemic, this was an essential tool to maintain patient access. Another way to improve access is to make transportation resources available to the patients. So although it's not available to all of our patients, there are some services that provide non-emergent transportation, or at least reimbursement for transportation costs for those who can't afford them, particularly in rural states like Iowa, where patients spend hours to try to get to their appointments. Services like the VA transportation system or the Medicaid non-emergency medical transportation services, or the travel reimbursement that's offered to some Medicaid patients is a really great way to get them here. So the biggest probably struggle that we've had in the last probably year and a half has been on staffing shortages, and this has had a huge impact on our patient access. The current reality that seems to be affecting patient access at my hospital is all about shortages. So here's a sampling of just some of the local headlines. The UI nurses protest regarding the nurse to patient ratio. Our largest hospital, which is where I am right now, is understaffed. Everyone's burnt out, and then the cost is critical, but obviously the shortages continue to get worse. Like everywhere else, we've had a mass exodus in nursing here. Clearly, there were staffing issues prior to the pandemic, but the effects of COVID amplified the problem by magnitudes that few of us could imagine. In fiscal year 2020, our hospital spent just over 10 million in traveling nurses. By 2021, 15 million. And last year alone, we spent $42 million. And
We are now only 3 months into fiscal year 23, and we've already, we're well on track to beat that, having spent already $23 million to date. Like others around the country, this has led to significant shutdown of patient access to various services, including the operating room. In September 2021, we were forced to close 5 to 14% of the general surgery rooms, and we're part of that department, due to the inability to staff them with nurses and scrub techs and now anesthesia staff. The decrease has obviously affected our volume by 5%, as our work RVUs are down by 7%. And it's also forcing more cases to be done during nights and weekends, which is only compounding the problem of staff burnout. Our vascular team is considered fully staffed at 24 FTE. We haven't had that level of staffing in years, even going back to pre-pandemic times. And we currently have 8 travelers and 3 non-travelers, and 1 has recently decided to quit. So pretty soon we're going to be even worse off than we were before. The nursing shortages have led to skyrocketing hospital labor costs. This is a nice paper out of New Orleans that collected data regarding the operating room, inpatient unit, outpatient clinic financials in over a 14-month period before COVID, and then looking at the 7 months afterwards, and then compared. On the graph on the right, you can see the COVID surges in the background in blue, and then you can see the increasing nursing costs in red. And then they maintained their RVUs, but the overall net profit to their group certainly has gone down as the price for labor has gone up. At our hospital, as is the case nationwide, the nurses are not the only ones in demand. There's a nationwide shortage of radiology techs that's also creating barriers to patient access. The demand is high, and it's projected to continue to grow, which provides them many opportunities to seek higher paid positions. And then we've also had a mass exodus of the radiology techs as well. Locally, the shortage has really limited our access to even be able to schedule elective endovascular procedures. And also our sonographers are in short staff. So during the middle of the pandemic, we lost 4 of our vascular techs, and this comprised approximately 40 years of experience that we lost out of the lab between the 4 of them. We finally now are back to the point where we are fully staffed again. But during that time of rebuilding the lab, we had actually our group as a whole had to decrease the number of studies we were ordering, which was, made us quite uncomfortable to not usually be able to survey our bypasses or, screen our patients like we would normally expect, because we just didn't have the staffing to do it anymore. So one more little dim thing to talk about. So vascular surgeons are also in demand, and this is also going to expected to be getting worse. By 2023 or 2034, the number of adults over age 85 or age 65 is expected to exceed the number of children for the first time in U.S. history. And so what that means for us is there are going to be a lot more vascular patients to be worked on. So because it is a disease of the elderly, the demand for vascular surgery is supposed to be expected to grow as well. And when you look at predictions, vascular surgery has the highest predicted growth rate compared to many other specialties. The Department of Human and Health Services also predicts that the demand will far exceed what we are able to provide by 2035. When you look at Dr. Go and colleagues actually looked at this, and when there is a little bit of a light at the end of the tunnel here, because after looking at the number of people who are graduating and also the number of expected patients in the future, it looks like by 2050, we will actually have enough in our workforce to meet the demand. Another paper that also came to the same conclusion showed that we are probably the only specialty that they looked at, having looked at 10 different specialties, where the expected workforce will actually meet the demand by 2050. So some solutions. So Jackson and colleagues stressed the need to recruit new vascular trainees, prevent early retirement and attrition. They suggested a rebranding of our field. with prioritization of work-life balance, increasing hospital administrative support, creating collaborative work environments, and facilitating personal accomplishments. Additionally, I think there should be a focus on increasing the diversity within our field. I think it's going to be critical to not only maintaining, but also growing the workforce. Dr. Olivola recently published a report of the SVS Task Force on Equity, Diversity, and Inclusion that assesses the current state of diversity within our specialty, and more importantly, outlines a multifaceted plan to move forward and make improvements in DEI. And I think just given where our numbers are right now, I think there's certainly a lot of room for improvement. When you look at the number of women and minorities in medical school, our numbers don't quite match up as a whole. So with that, I'd just like to thank everyone for the opportunity to talk tonight, and happy to answer any questions.
Well, that was a great presentation, Rachel. Thank you very much, and very granular data. So that was sort of eye-opening, I think, probably to many, and it just points out the challenges that we're going to have going forward. So thanks for shining a light on that. And I guess chin up, things aren't all bad, but man, there's a lot of data you presented. So thanks for presenting it. Next, I'd like to present Dr. Jay Chow. He's the Professor in Chief, Division of Vascular Surgery and Endovascular Therapy. He's the Brenda and Marshall Brown Master Clinician in Vascular Innovation, co-director of the Aortic Center at Case Western Reserve University School of Medicine and the University Hospitals Cleveland Medical Center. So he's going to just present on multidisciplinary approach to managing vascular disease. So welcome, Dr. Chow.
Jay, I'm not sure your audio is working.
Oh, I'm sorry. Good evening.
There we
Thanks for
go.
having me. Can you hear me okay? Okay,
Yes, we can now.
good. I have no relevant disclosures relevant to this topic. The prevalence of cardiovascular disease in the United States is extensive and growing. With the rapid growth of newer and sophisticated technologies, as well as advances in endovascular therapies, the modern approach to patients with vascular disease has become more complicated and has been rapidly evolving, including treatment paradigm shifts and involvement of many different medical specialties. This is a natural response of specialists to the evolving needs of our patients. The vascular surgeons acquired endovascular skill sets. Cardiologists are using their knowledge about atherosclerotic disease processes and their catheter skills to manage non-cardiac arterial diseases. Neurologists and neurosurgeons have learned endovascular technologies. Nephrologists are performing dialysis access related interventions, just to name a few. As a result, there is now much more overlap in the capabilities and the services offered and provided by each specialty, multidisciplinary team approach. MDT is not a new concept. It is best known in the field of oncology and has been shown to improve patient outcomes. There is evidence that its use increases adherence to guidelines in individual patients' outcomes. It's made of a team of healthcare professionals involving the nurses, dietitians, primary physicians, and specialists. Blood vessel is everywhere, involves every organ. And as such, management of blood vessels disease naturally involves most of medical specialties, if not all. And indeed, multiple papers have reported the benefits of multidisciplinary approach in the management of vascular patients with respect to outcomes, volume, amputation-free survival, and even coding accuracy and reimbursement. Aside from the direct patient impact, other benefits include cross-training. Trainees and faculty alike benefit from increased case volume case complexity and exposure to techniques and skills that are not necessarily unique to their own specialty. Our vascular surgeons and trainees have experienced a variety of techniques used by, for example, cardiac surgeons or cardiologists or even podiatrists that they would not have been exposed to otherwise. It also presents opportunities for academic pursuit. Combinations of data can lead to presentations and publications at a broader range. Increasing volume also translates to greater opportunity and chance to attract clinical trials. Resources such as data abstractors, statisticians, and other infrastructure can be shared and facilitate research efforts. However, it is not easy to form and maintain multidisciplinary team approach. We all have most likely personally witnessed or experienced the difficulties with forging such a relationship, especially a lasting working relationship. There was actually a paper recently that described a decreasing utilization of a multidisciplinary approach despite the beneficial effects on the outcomes. And that is because we are all humans and we have our own issues that we have to overcome, listed here. But we have to rise above these issues and overcome these hurdles. In order to overcome these hurdles, we have to dump this baggage that gets in the way of accomplishing our mission. And like I said, it's not easy. Sometimes it takes a village, as shown in this JAMA commentary. In my humble opinion, it takes actually even more than a village, more often than not. Aside from these issues, multidisciplinary approach are not usually offered to patients, particularly in patients with aortic pathology. This is in part due to the presentation of these patients often in urgent or emergency situations, and also because open surgery, particularly in the arena of thoracoabdominal aneurysms and arch lesions, open surgery is still considered as the gold standard. And furthermore, there's a lack of equally strong expertise in both open and endovascular options in many centers. And this leads to a decision bias towards one or the other option, which may not necessarily be the best option for the patient. To overcome these hurdles at university hospitals, Case Western Reserve University, we have formed the Aortic Center that is co-directed by both vascular and cardiac surgeons. We have a weekly aortic pre-op board meeting discussing most elective aortic cases from valve to aortic bifurcation. We discuss all endovascular and open options for each patient and come up with the best therapy for the patient. And we operate together for complex aortic cases, which has had a tremendous impact in more ways than one, as discussed earlier. To facilitate evaluation and treatment of urgent and emergency cases, we have implemented an aortic care team protocol that is activated whenever our referral center receives a call about any of these aortic catastrophes. And when ACT protocol is activated, both vascular and cardiac surgeons, as well as the intensivists on call, discuss the patient and decide on the best treatment. We have also established monthly aortic journal club, as well as aortic center quality initiative meetings to address any processes that may be related to the institution or process-related issues that may be attributable to the adverse outcomes, which may need to be corrected or addressed to improve the outcomes. We also have a quarterly citywide aortic conference where both vascular and cardiac surgeons come together to discuss complex cases as well as discussing articles. For the lower extremity arterial diseases, we have bi-weekly conferences where all specialties come together and discuss cases. We also instituted a limb salvage advisory committee where interventional cardiologist colleagues as well as vascular surgeons discuss every case before major amputation is entertained. We discuss all endo and open options, including deep vein arterialization, before we offer major amputation. And sometimes revascularization alone is not enough, as it does not comprehensively address the associated tissue loss and damage. So partnering with the plastic surgery service and podiatry has also allowed us to improve wound care and allow minimal or partial amputation when needed, as well as muscle flap and other coverage procedures that can facilitate limb salvage as well as in the management of graft infections. For venous diseases, we have a monthly conference with all services to discuss complex venous outflow obstructive disease as well as venous insufficiency patients, as well as complex or chronic IVC filter retrieval cases. So in summary, multidisciplinary team approach can be established at all levels of clinical care across multiple specialties to achieve optimal outcomes for both patients and physicians. We need to rise above superfluous and nefarious issues to forge long-lasting collaborative relationship. We also need to include a broader range of professionals, hospitalists, pharmacy, physiatrists, respiratory care, as listed here, to achieve better outcomes, and prospective studies to determine the impact of this approach on outcomes will be also needed. Thank you very much for your attention, and I'll be happy to entertain any questions. Thank you.
Thanks, Dr. Cho, and thanks to all the speakers. We've only got about 5 minutes left. So if you have further questions, we encourage you to go ahead and put them in the QA section. I'll start off. I'd love to ask Dr. Nicholson a question back to when you were talking about rural care and one of the solutions being telehealth. And I'm curious what you think are training programs, or if there's ways that we can encourage, or if it's even feasible for our trainees, to serve in some of those positions in rural. I feel like sometimes we don't give them any exposure to that. Therefore, it's rare that they want to go to rural areas. I just wanted to kind of get your opinion, or any of the other panelists as well.
Yeah, I think that's certainly an opportunity that even here where I'm in the middle of cornfields, it's we don't often do that part. I usually leave my telehealth visits to the end of my clinic, and by then it's like everyone kind of scatters. I go to my office and finish up the remainder of my clinic. Usually I finished off with doing the telehealth ones. But I think that it's certainly a missed opportunity. And I think especially with the projected shortages of vascular surgeons who serve rural areas expected in the future to only get worse, I feel like that's really something that we need to focus on. And it is it takes I think a different skill set that maybe needs to be practiced to really get an exam when you're doing a video visit, and to I think so, and there's certainly pluses and minuses to it. So but I think that having our trainees involved in that process is really important.
I have a follow-up question. It also sort of addresses the one in the chat, just regarding still those ruptured aneurysms that come in. So I'll throw this both to Joe and Jordan, whoever wants to bite on it. But regarding that, number one, sort of a two-part question: is there any data out there to suggest the number of aneurysms that are found incidentally by CTs for other reasons that weren't actually found during the screening process or under screening protocols? Because I think that addresses the question that came through on the chat, is that a lot of people should have got screening, they didn't. They're either coming in ruptured, or we're finding many of these incidentally.
I'll take a first bite on that, Dr. Molnar. So I think that there is a paper out about 4 years ago that looked at incidental diagnosis in cancer patients. And it was somewhere on the order of 20 to 25% with incidental vascular disease, and that will not necessarily aneurysms alone, but that concomitant risk factors in people that aren't otherwise screened. I also think that if we look, we haven't made a huge dent in our ruptured aneurysm overall volumes, which I think would also speak to that. While we had initial decrease in the EVAR data, if we continue to look in our Medicare data, we have not made a huge decrease in ruptured aneurysm treatments in the last 5 to 10 years.
Yeah, and I think the other important part of that is that you almost have to take it, I hate to say it, but you almost have to take it out of the hands of the practitioners. So I do think that some of the modeling and the data acquisition that's available can hopefully fill in some of those gaps that we're missing. And obviously, on a more local level, anytime I see a patient who's referred for venous disease, carotids, whatever, other things, if they haven't had their screening, I don't send a letter back to the PCP saying, get screening on them. I send a letter back saying, hey, by the way, this is the best practices, and we're going to get the ultrasound screening for your patient. And then hopefully that's just a way of encouraging that. Because I do think that in the rural communities, at least where I go out to do outreach, a lot of the primary care is mid-level providers. There's just not enough even primary care doctors to staff a lot of those clinics. And it's just not a priority for them to be worrying about preventative things when they have so many other, medical illnesses that they're trying to manage. And, one lone nurse practitioner taking care of a population of several thousand sometimes. So.
I'd like to, oh, go
I'm sorry.
ahead.
I want to go back and answer the telehealth question, if I may. I want to encourage a lot of vascular surgeons to do it. I started doing telehealth in 2015 and just getting more and more comfortable. I've done hundreds of them now that I feel very comfortable. And what I've done during the pandemic, obviously, is we can't have that face-to-face. What I've now is modify it so that, let's say, I started with doing venous because I figured that was much easier. They can do ultrasounds and our outline. When I was in a big multi-institutional center. Now, what I did last week was, in the past few months is people we had the same issue in Michigan. This patient came from the UP, Upper Peninsula, where the nearest pharmacy was an hour away on Drummond Island. There's no pharmacy, no doctors up there. And he had to get his CAT scan 3 hours away. It's about 6 hours to drive to Lansing. So what I did was when I did the initial health visit, I actually sent him up for an echo and ABI, and then he sent me the disc. I was able to review it ahead of time. And the first thing the people were like, well, how are you going to set up? And I think you have to encourage your schedulers to set these up. Oh, he's driving 6 hours away. Have you thought about telemedicine? They're like, well, they didn't know. So it's something that you have to introduce to your patients and say, this is a possibility. We can do Zoom meetings. And I wasn't sure if there's internet access up in Drummond Island, but they have great internet actually. Thanks to some of the governor in Michigan and some of the initiatives. So that was not an issue. And then you have to make sure that they have the technology up there, obviously. And then he came down and got the echo on the same day. He drove 5 hours, 6 hours, saw me, got the testing done, and then drove back the same day. And then he came back this Tuesday, Monday for the Tuesday. We did an aortal bifemoral bypass with bilateral femoral endarterectomy. And because he has a TAS D lesion. And then he's doing great post-op day 3. He's going to go home, hopefully post-op day 4, actually. And I was a little worried, but I think he's going to be fine. He wants to go home and then come back for his staple removal. I guess he likes to drive, or has his friend drive. But I think there's things that you can do where I said, stick around in this area. And the other thing I did was a lot of renal vein nutcracker. They're all over the country. The nutcracker patients is another one that likes to get multiple opinions. And so I'm usually one of the, 8th or 9th opinion, or they go see so many different doctors. And I think that's also another one where they send me their CD. I look at them. I look at their symptoms. I don't need to physically examine them, but I need to virtually talk to them, face to face, even though it's telehealth. I think that's another one that I thought was pretty helpful. A lot of them are also out of state as well, so that was a little challenging. But during the pandemic, that opened up a lot of possibilities. So I think we really have to leverage telehealth for these patients to make it easier, just to set it up before or after. Sometimes they're not quite sure of the symptoms. Then I have to, most of the time I can answer the questions through the televisit. But if not, save them another trip, or at least I could get something set up, another CAT scan or something, or ultrasound near their home, and then be able to sort of talk with them. And it's more visual acuity, visual and then also listening to what they have to say. And a lot of these visits, you can get a lot of information just through the telemedicine visits.
Yeah, well, you've certainly pioneered a lot of that, Dr. Lin. We appreciate that in the vascular surgery world. I just want to, I know we're over time, but I just want to ask one more really brief question of Dr. Cho. I mean, you've shown some great success in working in a multidisciplinary way. And I would say in my career, we had some successes and some non-successes. And I'm just curious, were your successes more pioneered by you and your team? Were they pushed by the hospital? Was it a combination of efforts? And do you think it's, sustainable over the long term?
I think you're muted.
Audio.
I'm sorry. I think it was a combination of things. We have a very strong working relationship with interventional cardiologists and vascular surgeons. We cover pretty large surface area with the 9 different hospitals where vascular surgery is covered. And as a matter of fact, we cannot have 2 or 3 vascular surgeons at each of these satellite hospitals. Obviously, we have 5 or 6 surgeons at the main university hospital. But in the satellite hospitals where we do not have 2 or 3 surgeons, actually for lower extremity ischemic emergencies, those calls are actually taken by interventional cardiologists. Now, obviously, for issues that are not amenable to interventional cardiologists, they get transferred to the main campus. So we have forged a very strong working relationship with the cardiologists and vascular surgeons. So that was sort of extended to cardiac surgery. And we have a cardiac surgeon who actually has independent privileges to do TVAR, and he has a very strong vested interest in aortic surgery. So with the talented cardiac surgeon who has independent privilege to do TVAR, we had a much deeper understanding when we discuss aortic pathology between vascular and cardiac surgeons, and that sort of promoted even or fostered a stronger working relationship between the 2 units. So it sort of things kind of came together and congealed. This strong working relationship across different specialties, and we were actually able to rise above, this baggage or turf battle, and however you want to describe it, and that's how we were able to forge this very strong working relationship. So it's sort of a process of evolution with everybody having common interest towards mission of providing best care, increasing our volume, things of that nature.
Well, I think, again, we've sort of run out of time. I want to thank everyone again for their participation, all those that are on the webinar, and of course our presenters. I think we could have spent an hour on each of the topics tonight, and probably has some longevity to find other webinars that will be taking places in the months to come. But thank you everyone for attending, and again, like to thank Medtronic for sponsoring this. Hope everyone has a wonderful holiday season, and have a good evening.
Thank you.
Good night.
Bye, everybody.
Good night, everyone.